Namaste Bitya. Hamesha Khush Raho Bitya. A very good morning to you all. Myself, JVN Dr. Abhijan, Assistant Professor, Department of Practice of Medicine in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, JAIPUR. In this series, we are discussing about the diseases of the respiratory tract. Today, we are going to discuss about bronchial asthma. What is bronchial asthma? What are the etiopathogenesis, the changes that are occurring in lungs in case of bronchial asthma, the clinical features of bronchial asthma, the investigations, and the management. In the last lectures, we had discussed about different other diseases related to the respiratory system. And today we are going to finish this topic of bronchial asthma. Bronchial asthma will be covered in 2 to 3 lectures. So let's start with bronchial asthma. In the presentation that I have uploaded with this portal, I have shown you the pictures of different changes in the airways that are occurring in the normal condition as well as in the asthmatic condition. In the asthma, there is usually narrowing of the airways. Narrowing of the airways means the normal airways are getting constricted or shrunken down so that the air is not able to flow properly in that particular given condition, leading to the development of bronchial asthma. So what is asthma? Asthma is basically a syndrome. Syndrome means group of symptoms that is characterized by airflow obstruction. There is obstruction to the flow airflow and increased airway hyperresponsiveness. So it is a syndrome that is characterized by airflow obstruction that varies markedly, both spontaneously and with the treatment. So in asthma, we have the obstruction in the airflow, and it is both spontaneous with the treatment. So after the treatment, there is marked variation in the narrowing or the obstruction of the airflow. Asthma shows chronic airway inflammation. There is chronic airway inflammation in the asthma, and there is increased airway hyperresponsiveness. So we have chronic inflammation and increased airway hyperresponsiveness in bronchial asthma. The typical symptoms of bronchial asthma includes wheezing. Wheezing is the narrow sound or the whistle-like sound that is heard because of the passage of air through the narrowed blood vessels. There are typical symptoms of wheezes, cough, chest tightness, and dyspnea. So we have wheeze, we have cough, we have chest tightness, and we have dyspnea that is occurring. It is accompanied by the presence of airflow obstruction. There is obstruction in the airflow that is variable over the short period of time. The inflammation in the airways makes it more responsive to a wide range of triggers. So there is inflammation and it makes it more responsive to the wide range of triggers, leading to the excessive narrowing with consequent reduced airflow and symptomatic wheezing and dyspnea. So what is happening in asthma? It is a syndrome that is characterized by airflow obstruction, and it varies markedly both spontaneously with the treatment. The asthma shows chronic airway inflammation and increased airway hyperresponsiveness. There are typical symptoms which includes wheezes, cough, chest tightness, and dyspnea. It is accompanied by the presence of airflow obstruction that is variable over the short period of time. The inflammation in the airways make it more responsive to a wide variety of the triggers, and it is leading to excessive narrowing with consequent reduced airflow and symptomatic wheezing, and dyspnea. There is narrowing of the airways, and it is usually reversible. But some patients with chronic asthma, there may be element of irreversible airway obstruction. So usually the obstruction or the narrowing of the airways in case of bronchial asthma is reversible, but in some cases it can become irreversible. The symptoms are usually reversible with treatment. So as soon as we prescribe the treatment to the patient, the symptoms are usually getting reversed. So there was inflammation in the airways. It was spontaneous hyperresponsiveness of the airways to various stimuli. There was presence of airflow obstruction that is variable over the short period of time. There are inflammation of the airways which make it hyperresponsiveness to various triggers, leading to excessive narrowing with consequent reduced airflow and subsequent wheezing and dyspnea. There is narrowing of the airways, which is usually reversible with some patient. With chronic asthma, there may be an element of irreversible airflow obstruction. The symptoms are reversible with the treatment. The prevalence. It is one of the most common chronic disease. The prevalence is one of the most common chronic disease, and it affects approximately 300 million people worldwide. The prevalence is rising constantly with time, and it is associated with increased urbanization. The more the urbanization and the more is the incidence for development or prevalence for development of bronchial asthma. The prevalence of atopy and other allergic diseases have also increased. So it is one of the most common chronic disease, and it is affecting approximately 300 million people worldwide. There is increased prevalence, and it is associated with the increased urbanization. The prevalence of atopy and other allergic disease, it is also increased, and more patients with asthma in affluent countries are atopic. Atopy is the hypersensitivity. With allergic sensitization to the household dust mite, dermatophagoides, pteronosis, sinus, and the other environmental allergens. Next is the incidence. The patient of bronchial asthma have increased steadily over the latter part of the last century. It is most common with any age group, and the peak age is 3 years of age. In the childhood, twice as many males as females are asthmatic, so more common among the males. But in adulthood, the sex ratio is equalized. So in the childhood, males are twice affected in comparison to females, but during adulthood, the sex ratio is equalized. The children may become asymptomatic during adolescence, but that asthma returns in some of the adult life. The socio-economic impact is enormous. There is an important role of microbial exposure, diet, vitamins, breastfeeding, air pollution, and obesity. So we have an important role of the microbiological exposure, diet, vitamins, breastfeeding, air pollution, and obesity in the development of bronchial asthma. Next, we come to the risk factors. What are the various risk factors? Asthma is a heterogeneous disease, and it is developing with the interplay of various types of genetic and environmental factors. So it is basically a heterogeneous disease that is manifesting in different ways. And there is an interplay between the genetic and the environmental factors that are responsible for development of bronchial asthma. There are various endogenous factors, which includes genetic predisposition, atopy, etc. Environmental factors consist of allergens and occupants, etc. The trigger factors include various types of allergens, cold air, exercise, stress, etc. So asthma is basically a heterogeneous disorder that is with the interplay between the genetic and the environmental factors. There are various endogenous factors with genetic predisposition, atopy, etc. Various types of environmental factors like allergens, occupation, etc. are responsible. Trigger factors includes allergens, cold air, exercise, stress, etc. Next, we have atopy. What is atopy? Atopy is a predisposition towards developing certain allergic hypersensitivity reactions. So what is atopy? Atopy is basically a hypersensitivity or a predisposition towards developing certain allergic hypersensitivity reactions. Patients with asthma commonly suffer from other atopic disease, particularly allergic rhinitis and atopic dermatitis. So this is basically an atopic disease, and atopy is a predisposition towards development of certain allergic hypersensitivity reactions. The patient with asthma commonly suffer from atopic diseases like allergic rhinitis and atopic dermatitis. The most common allergens are derived from the house dust mite, cats, dog fur, cockroaches in the inner cities, grass and tree pollens, and rodents. There is production of specific IgE antibodies. Next, we come to asthma. Asthma shows a chronic airway inflammation and increased airway hyperresponsiveness. So we have chronic airway inflammation and increased airway hyperresponsiveness. The typical symptoms include the chest pain, tightness, breathlessness, and wheeze with cough. So we have wheezing, coughing, chest tightness, and dyspnea. Wheezing, coughing, chest tightness, and dyspnea. It is accompanied by the presence of airflow obstruction that is variable over the short period of time. The symptoms are reversible with treatment. In the pathophysiology, asthma is associated with specific chronic inflammation of the mucosa of the lower airways. So there is chronic inflammation of the mucosa of the lower airways. There is airway hyperreactivity with a tendency for airways to contract too easily and too much in response triggers. In the pathology is revealed after the examination of the lung of the patient who had died of asthma and from the bronchial biopsies. The airway mucosa is infiltrated by activated eosinophils and T lymphocytes. And there is an activation of the mucosal mast cells. So there is activation of mucosal mast cells. The degree of inflammation may even be found in atopic patients without asthma symptoms. In the persistent asthma, a chronic and a complex inflammatory response ensues, which is characterized by influx of numerous inflammatory cells, the transformation and the participation of airway structural cells, and the secretion of array of cytokinins, chemokines, and growth factors. So in the persistent asthma, there is a chronic and complex inflammatory response that assures, which is characterized by the influx of numerous inflammatory cells, transformation, and participation of the airway structural cells. There is secretion of the arrays of cytokinins, chemokines, and the growth factors. There are various smooth muscles. There is smooth muscular hypertrophy and hyperplasia. So there is hypertrophy and hyperplasia of the smooth muscles with the thickening of the basement membrane. There is mucus plugging and the epithelial damage. There are structural changes in the airways that is known as remodeling. There is thickening of the basement membrane due to subepithelial collagen deposition. The airway walls is thickened and edematous, particularly in the fatal asthma. There is also occlusion of the airways, airway lumen by the mucus plug. There is also vasodilatation and the increased number of blood vessels that is known as angiogenesis. So we have smooth muscle hypertrophy and hyperplasia with the thickening of the basement membrane, mucus plugging and epithelial damage. There are structural changes in the airways that is known as remodeling, thickening of the basement membrane due to subepithelial collagen deposition, and the airway wall is thickened and edematous, particularly in the fatal asthma. There is also occlusion of the airway lumen by plug mucus plug. There is also vasodilatation and increased number of blood vessels that is known as angiogenesis. The airways are narrowed with erythematous and edematous. There are pathological changes that are found in all the airways. There is inflammation in the respiratory mucosa from trachea to terminal bronchioles, but with the prominence of bronchi. There are inhalations of the allergens into the airways. It is followed by two-phase bronchoconstrictor response with both an elderly and a late phase response. Many inflammatory cells are involved in asthma that are mast cells, macrophages and dendritic cells. We have eosinophils, we have neutrophils and T lymphocytes, etc. So there are various inflammatory cells that are involved, which includes mast cells, macrophages and dendritic cells, eosinophils, neutrophils and T lymphocytes. So let's have a quick revision of the bronchial asthma. In bronchial asthma, there is airway remodeling with the several changes in the structure of the airway that are characteristically found in asthma. And these may lead to the irreversible narrowing of the airways. In the physiology, there is limitation of the airflow and is mainly due to bronchoconstriction. But airway edema, vascular congestion, and luminal occlusion with exudate can occur. There is airway hyperresponsiveness. Airway hyperresponsiveness is the characteristic pathophysiological abnormality in asthma and describes the excessive bronchoconstrictor response to multiple inhaled triggers, and that would have no effect on the normal airways. So this was all about bronchial asthma. Now you have to perform or write the answer of the question, what is bronchial asthma? And you have to write the etiology, pathogenesis, and write in brief about the etiology. Other questions I have uploaded on the portal. So this was all for today. This was all about bronchial asthma. In the next lecture, we are going to continue with the clinical features of bronchial asthma and the investigation and management. So this was all for today. Thank you very much. Have a good day.